All PACU staff to the front desk for safety huddle. All PACU staff to the front desk for the safety huddle. Okay, everyone. Are there any high-risk patients on the floor today?
We had a patient on the 6th floor who was a little bit unstable last night, but is otherwise doing fine as of this morning.
Okay, great. Any fall risks?
I believe on that floor we have bed 2B is a fall risk, and 16A.
And any last name, first name issues, nothing like that? Okay, great. And how is the bed situation in the hospital?
Telly's good. Med-Surg has 3 beds. Onca, I think, has 6 pending discharge, and I believe the other surge floor is full.
Okay, great. So just full. And any staffing issues, sick calls, anything like that? Nope. We're good for today. All right. And I just wanted to bring up a situation that happened on the floor last Friday where an insulin overdose occurred on a compromised patient, and Catherine's here to talk about that a little bit.
So last weekend we had kind of a crazy weekend, a kind of crazy Friday night. So we had 3 emergent surgeries that came into the OR, and we were understaffed already to begin with. So I was the OR nurse for these 3 surgeries, and we had a resident anesthesiologist as well as an anesthesiologist and another OR nurse and a CRNA that was with us for the night.
Okay.
So we had 3 emergent surgeries, like I said. At around 3 a.m., the situation that you're talking about occurred where a patient on the floor was severely sick and had a blocked bowel along with a bunch of different other comorbidities, including an MI previously. And he actually came into the OR and was very hyperglycemic. So what happened is that there was insulin ordered, and it was 10 units is what the resident called out to the OR staff, and the resident anesthesiologist went to go drop the medication and happened to drop 10 cc's instead of 10 units of insulin from the Pyxis machine. He pushed this medication IV instead of titrating it into an IV bag and putting it through the pump. I guess the way the situation occurred was that the orders were not very clear about which method he was to use, and he got a little bit confused. As well as I feel a huge part of the situation was we had been in the OR with a bunch of different emergent cases for pushing 13, 14 hours, and we were all very tired and trying to go home. I know it was a holiday as well, so everyone, was just very, very quick to act, and the patient ended up being critically ill and made it out of surgery fine, and we did address the situation. But I just feel like there's a bunch of different things that need to be implemented. So I talked and worked closely with Angelica Stave, who I made a phone call to early Saturday morning, and we worked together, and we just felt that there are a few in-service trainings that need to be done in order to prevent this situation from happening for all OR staffing, because I know it's happened before, and it'll probably happen again, and I just think we need to make sure that we're all treated properly in this situation. So I talked to her.
Right, so after analyzing the situation, we found that the 2 main causes were really the fatigue. Like you said, you guys had a lot of cases that weekend, you were in the OR for so long, and I understand that the resident anesthesiologist was coming to the end of a 24-hour shift, which is, we know that's not supposed to happen. And also the lack of the double check and just the confusion with the orders. So in order to prevent these problems from happening again, the hospital has decided to really put hard shift limits. We're really gonna enforce those. And we're also going to make this possible by hiring staff in the next couple of months. We're going to be hiring a bunch of new staff so we can really stick to these shift limits. We're also going to have reminders of the double check by doing in-services on all of the floors. And we're really going to enforce people to be putting in orders and scanning them in before they're given to patients so we don't have confusion like this. Does anyone have any comments or questions?
I do.
Yeah.
So in these emergent situations, when we have a compromised patient, we have to rush to the OR. How are we supposed to implement that, like the double checks and confirm the orders with the physician if the patient's compromised and we need to act quickly?
Right, we understand there's like high acuity situations and emergencies where you can't always put in that order and scan it. So we're gonna just really emphasize that we do verbal double checks where you have multiple people looking at meds and making sure that they're good for patients, especially in those high acuity situations. So.
Okay, and then is there a method that is going to go with evaluating how these changes were implemented?
Yeah, so after a month when everyone's done their in-services, we've hired a couple new staff we're gonna just evaluate all the changes and see how it's affected the medication overdoses.
I also just believe that in the Epic system, when you're using it, I think if you scan the patient before surgery, I know that the patient stays scanned for probably a 3 to 4 hour period, which I know sometimes surgeries can take longer than that. But, you know, if you already have your meds drawn up before surgery, which the majority of the time as an OR nurse you do have, and the resident anesthesiologist should also be doing that with you, it's very important because if you scan the medication quick, it's, 2 seconds longer?
Right.
So the computer will pop up most likely with an alert message saying, you know, too much insulin or whatever you're given too much insulin or you have drawn up too much insulin, whatever it may be. So I think that 2 seconds is life or death for a patient in this, in an emergency situation.
agree.
So.
Okay, great. Anyone else have any questions, comments about anything we're good with?
Sounds good.
Okay, great. We'll be back for the 2 p.m. safety head later.
Back to you.
All right, keep up the
Thank
good
you.
work.